right, we're going to start on the lecture of newborn. Lots of things happen when the baby's born. Respiratory system, fluid-filled, high-pressure system, which causes blood to be shunted from the lungs through the ductus arteriosus to the rest of the body. And then after the baby's born, the baby has to breathe. Air-filled, low-pressure system encourages blood through the lungs. So the lungs now have to become the organ of gas exchange, and increased oxygen content of blood in the lungs contributes to the closing of the ductus arteriosus, which becomes a ligament. And your site of gas exchange is now the lungs, no longer the placenta. And in the heart, the ductus arteriosus and the foramen ovale both have to close. So we have to go from fetal circulation to adult circulation. And thermoregulation, body temperature is maintained through the flexed posture, through non-shivering thermogenesis, metabolization of brown fat. So we know that we'll talk about the different ways babies can lose heat, and what we have to do is to prevent that from happening. So maintaining thermal regulation, that is totally the nurse's responsibility. And the cardiovascular system, we're on slide number 3. So we're switching from fetal to newborn. Lots of things involved. Physical forces leading to increased release of catecholamine, critical for changes involved in transition to extrauterine life. So successful transition from fetal to postnatal circulation requires increased pulmonary blood flow, removal of placenta, closure of the foramen ovale, and the ductus venosus and ductus arteriosus. So when the umbilical cord is clamped, the first breath is taken, and the lungs begin to function. As a result, systemic vascular resistance increases, blood returns to the heart via the inferior vena cava decreases. There is a rapid decrease in pulmonary vascular resistance, which is extremely important, so that blood can go into the lungs for gas exchange. And then you've got increased left atrial pressure, which causes the foramen ovale. It's like an opening between the atria. It's like a one-way door, and as the pressure goes up in the left atrium, it just shuts that door. Whereas the ductus arteriosus is the little connection between the pulmonary artery and the aorta, and it just has to constrict. Okay, newborn lab values, and you do need to know these because there will be a test question. You'll just have to identify which result you would notify the physician about. So hemoglobin 16 to 18 grams per deciliter, hematocrit 46 to 68, platelets 150 to 350,000, RBCs 4.5 to 7, and white blood cells 10 to 30. White blood cells can be elevated just from the stress of labor, and it be normal the first day in the baby and or mom. So summary of fetal to neonatal circulation, we just went through all of that. Respiratory system adaptations. So the babies have to adjust from fluid-filled intrauterine environment to gaseous extrauterine environment. Surfactant is very important. That's the problem you have with respiratory distress syndrome. You don't have enough surfactant. Surfactant is a phospholipid that decreases surface tension. So it's surface tension reducing lipoprotein that prevents alveolar collapse. So that's really important. Normal respiratory rate is 30 to 60 breaths per minute. And they are irregular, shallow, unlabored. And you can apnea is cessation of breathing 20 seconds or longer. So you just have irregular little stops. We don't call it apnea unless it's 20 seconds or more. And it really helps if the baby can be born vaginally and get that vaginal squeeze as it comes down the birth canal. That will help to squeeze the fluid out of the lungs. initiation of respiratory movement, expansion of the lungs. The baby's got to breathe in and establish their functional residual capacity. And of course, the blood has to increase, go into the lungs. So respiratory rate of 45, normal. Yes, 30 to 60 is considered normal. So we're on slide number 10. And characteristics predisposing newborn to heat loss. They got thin skin, and the more preemie they are, like a 27-week or just maybe a layer of cells, and then as they come from the aquatic environment to the atmosphere, keratinization occurs in 7 to 10 days. They're much more able to, like the preemies, to control their thermal regulation. Lack of shivering ability, limited stores of metabolic substrates, and limited use of voluntary muscle activity, and they have extremely large body surface area relative to their body weight, and lack of sub-Q fat. So they just have little ability to conserve heat by changing posture, and the more term baby will flex trying to maintain its temp. So if you can just get them skin to skin with mom's breast, that area is extremely warm, so you can just kind of dry them lightly, lay them on mom, dry their head, put a cap on their head. And of course, infants can't tell us if they're too cold. They can't communicate what's going on. And there is at least one question on slide number 11, mechanisms of heat exchange. So conduction is, if I take a baby and I put it on a cold scale without anything warm on it, so it's transfer of heat from object to object. So transfer of heat from the baby to the cold scale when the two objects are in direct contact with each other. Convection is flow of heat from body surface to cooler surrounding air to air circulating over a body surface. An example would be a baby's laying in a crib and there's a fan just blowing air, back and forth over the baby. The baby would have convective heat loss. So it's really important to let the parents know they, don't need to have the babies directly under a fan. Evaporation's loss of heat when a liquid is converted to a vapor. So when babies are born, we're going to dry them off because of evaporation, evaporative loss. Then we're going to take that cold towel that's wet and throw it away, because if we leave that in contact with the baby, then that's conduction. Then radiation, so our little plastic sides, we always warm the warmer up before we put the baby in so that those can be warm, because radiation, it's like if you stand in front of a window, your heat will radiate towards, a cool window. So radiation is loss of body heat to cooler solid surfaces in close proximity, but not in direct contact. So you will have a scenario that just describes the situation and you'll have to answer. And this gives you an example. So there's the baby on the cold scale. There's the baby that air is flowing over it. Evaporation, the baby's wet. So like when you bathe a baby and they're wet, they can have evaporative loss. And then the radiation towards the cold, the window. So slide number 13, thermoregulation of the newborn. Thermoregulation is balance between heat loss and heat production. So they produce heat primarily through non-shivering thermogenesis. And let's see, slide we're on. So we have radiant warmers, and we just connect a little probe over the liver. Infrared rays just radiate, and they heat the blood in the capillaries, and then this blood goes core. That's the reason the only thing the baby has on is a diaper. And we know the different ways they lose heat, so we're going to do everything we can to prevent them from losing heat. And if a baby, you take a temperature and the baby, let's say, is cold, maybe it stayed in L&D too long, they didn't keep it covered up, and it comes to you and it's maybe like 96.5, Babies can be symptomatic with hypothermia, and the thing of it is, we just rewarm them gradually. You don't try to rewarm them really fast. So you'll just put them under the radiant warmer and just turn your probe on 36.5 and just let them slowly heat up. So we have to identify hypothermia when we take the temperature, and then we'll just a gradual rewarm. You need to remember that. Okay, slide 14 is just talking about hepatic. Usually a term newborn's blood glucose level is 70 to 80% of the maternal blood glucose level at birth. So hypoglycemia is one of the most frequent problems encountered, especially with your LGA or your IGR babies. So it's really important if they're high risk. We don't do a blood sugar check on everybody, just if there's no prenatal care or if they're identified in a high-risk group. So glucose is the main source of energy for the first several hours after birth. And also the liver, the placenta has taken care of getting rid of bilirubin. So then once the placenta's gone, the liver has to do it. And it just takes the liver a little bit of time. So you're always going to have that physiologic jaundice, like 72 to 96 hours. Bilirubin normally circulates in plasma, is taken up by the liver cells, and is changed to a water-soluble pigment that is excreted in the bile. And this is called conjugation. This conjugated form of bilirubin is excreted from liver cells as a constituent of bile. So, gastrointestinal, it takes a while for them to be able to increase the size of their stomach. When they're first born, their stomach maybe the size of their fists. 15 milliliters is plenty for a feeding, and you have to burp them real often. And cardiac sphincter is immature, and nervous control of the stomach are immature, so that they will have a lot of regurgitation. You need to know that, regurgitation, because of immaturity of the cardiac sphincter and nervous control of the stomach. So we feed them small amounts, we burp them often. That's really important. And to be able to gain weight, they need about 110 kcal per kilo per day. So, and then we'll talk about our formula later because it's about 20 calories per ounce. There is a question on meconium stools. So we've got meconium, then transitional, then milk stools, and then you need to know the difference. Meconium is that first stool that's tarry, pasty, and then you've got your breastfed stools. And breastfed stools are yellow gold, loose, stringy to pasty, and sour smelling. Then, of course, your formula is just a yellow-green or formed. But the breastfed has that sour smelling yellow gold, and they're very loose. And normally every time a baby breastfeeds, they stool with breastfed babies. And it's the babies need to pass that meconium within the first 24 hours of age. So it's really important to document when the baby has the first stool. So when assessing the stools of a 1-week-old, we're in slide number 17, newborn who's being breastfed, which would the nurse expect to find? Yellow gold, loose stool, sour smelling. The greenish black tarry stool would suggest meconium. Renal system, we're on slide number 19 in chapter 17. Limited ability to concentrate urine until about 3 months of age. And when we're trying to assess, like, is a baby getting enough fluid intake, about 6 to 8 voids per day is considered normal. Immune system, it really helps if they breastfeed and get antibodies from mom. And of course, the skin is extremely important. It's the largest organ in the body. And I've already told you you'll have accelerated epidermal development with exposure to air for all newborns, and that includes your preemies. Neurologic system adaptation. There's going to be a question about this. So development follows cephalocaudal, head to toe, and proximal distal patterns from in to out. So that's really important. Development follows cephalocaudal and proximal distal patterns, acute senses of hearing, smelling, touch, taste, and vision. And the sense that is the least mature at birth is vision. They can hear extremely well, but vision is the weakest of all the senses at birth. Reflexes, they're really important to have our primitive reflexes. We'll talk about them more because there's going to be a couple of reflex questions on your test. Reflexes, indication of neurological development and function. So, which is the least mature sense at birth? And I've already told you it is vision. Okay, we're on slide number 25. Behavioral patterns of newborns. First period of reactivity, birth to 30 minutes to 2 hours after birth. So that's when they need to breastfeed. They're alert, may appear hungry, and then after that they'll go to sleep, and then they have a second period. No, during the first period they are awake. 28, this is just talking about newborn behavioral responses. Orientation, which is a response to stimuli. Habituation, ability to process and respond to auditory and visual stimuli, ability to block out external stimuli after newborn has become used to activity. Motor maturity, ability to control movements. Self-quieting ability, so hopefully they will be able, especially once they go home. Social behaviors are really important for bonding and attachment, cuddling and snuggling. Okay, let's see if we can go to the next chapter. Okay, so we're in chapter 18. I hope this is showing up for you all. So initial newborn assessment is really important because if there's something wrong with the baby, we need to be able to find out. So that's what reason we look. First, you're going to observe. Just look at your baby. Look at the breathing. Look at their color. Look at their posture. Are they having any signs of respiratory distress? Nasal flaring. When the nares flare, that's just trying to decrease airway resistance. The more preemies may have retractions. Grunting on exhalation. When you hear that, that's like with respiratory distress syndrome. And when they grunt, they are blowing against a partially closed glottis, trying to create their own CPAP, continuous positive airway pressure. So your RDS babies, you can just hear them from one end of the nursery to the other. It's just like, hee. They're just like singing as they do this grunting. Generalized cyanosis. When we talk about cyanosis, we're talking about central cyanosis of the mucous membranes. Flaccid body posture, like your term babies should be all flexed. If they're just like extended and limp, that's hypotonia. That is not good. Abnormal breath sounds. We can expect to hear some crackles, especially with our C-section babies. Some retained amniotic fluid. And rate 30 to 60. Heart rate should be around 120 to 160. I'm on slide number 3 in chapter 18. So APGAR scoring, we'll talk about that. You do a 1 minute and you do a 5 minute, so you do it twice. And the 5 minute is more predictive of overall outcome. Lots of babies kind of get in a little bit of trouble right there at the end. They just need a little jump start and you can just get them going. So really the 5 minute will tell you if it's your APGAR still down at 5 minutes. It's much more severe than just an initial low APGAR that we immediately get up. Length is measured from the head of the newborn to the heel with the newborn unclothed. So you're going to place the newborn in a supine position, extend the leg completely when measuring the length, and the expected length range of a full-term newborn is usually 44 to 55 centimeters or 17 to 22 inches. And then, molding itself can affect the measurement. If it's a cone-shaped head, it might make the baby appear to be longer. Most often, newborns are weighed using a digital scale that reads in weight in grams. So typically, your newborn weighs 2,500 to 4,000 grams, which is equal to 5 pounds, 8 ounces, to 8 pounds, 14 ounces. And babies will lose 10% of their birth weight the first, few days. They're 70% water, and then they've got their meconium, and then they'll gain it back in 7 to 10 days. And so usually regained by the 10th day of life. And babies can be classified by their birth weight regardless of their gestational age. This is according to the American Academy of Pediatrics. So low birth weight is less than 2,500 grams or 5.5 pounds. And you need to know all of this. You're going to have to memorize this. Very low birth weight is less than 1,500 grams or 3.5 pounds. Extremely low birth weight is less than 1,000 grams or 2.5 pounds. So when we look at our APGAR scoring, this is on slide number 4. Appearance, pulse, heart rate, G for grimace, reflex irritability, A for activity, muscle tone, and R for respiratory effort. So we do it at 1 minute and we do it at 5 minutes. And this just shows you. So if your heart rate, if you don't have a heart rate, it's 0. Below 100 is 1 point. Above 100 is 2. If you have slow, irregular, shallow, that's 1 point. If you have regular respirations, 30 to 60. With a good cry, that's usually 2 points. Muscle tone, limp and flaccid is 0. Some flexion is 1. Good flexion is 2. If they have a grimace or frown when irritated, is 1 point. Sneeze, cough, vigorous cry is 2 points. Skin color, and they all have that acrocyanosis, which is the blue fingers and toes, first couple of days, and that's just a transient vasomotor instability. So they'll just get 1 for that. And then when everything's blue, they'll get 2. And most time APGARs are like 8, 9. Newborn vital signs. So your temp, 97.7 to 99. Heart rate, usually that says 110. It's 120 to 160. If a baby's sleeping, it actually may be 90, and that's okay. So this is when they're awake. Respirations, 30 to 60. And then blood pressure, you just have to look that up in your charts. Gestational age. I don't know. I haven't finished the test, so I probably will put a question about this. Preterm or premature is prior to 37 weeks gestation. A term infant is 38 to 42 weeks, and we're on slide number 7. Post-term or post-dates is after week 42 of gestation, and post-mature after week 2 of gestation with signs of placental aging, and the placenta doesn't function well. You know, it starts going downhill after about 40 weeks. I'll be right back. I've got to run to the restroom. Okay, now we're going to be looking at gestational age. So we've got, this is slide number 8. Small for gestational age, appropriate for gestational age, and large for gestational age. So your SGA is less than 10%, appropriate's 90, is 10 to 90, and over 90 on your growth charts is LGA, and we'll talk about that some more in a minute. So when we look at gestational age assessment, we have our physical criteria and then neurological criteria. The Ballard score helps to determine gestational age, and skin texture. Lanugo, that's the soft downy hair on the newborn's body. Plantar creases, breast tissue, eyes and ears, genitals, and I gave you a copy of that in your lab course. Then your neuromuscular maturity. If they're sick, you can't really use this. You have to wait. It's not as accurate if they're sick. So we take all of these and then we just add the points up, and you just look at your little handout. So after your scoring is complete, the 12 scores are totaled and then compared with standardized values to determine the appropriate gestational age in weeks. Scores range from very low in preterm newborns to very high for mature and post-mature. So you're small for gestational age, weight less than the 10th percentile on standard growth charts, and that's usually less than 5.5 pounds. Appropriate for gestational age, weight between 10th and the 90th percentile, and large for gestational age, weight is more than 90 percentile on standard growth charts. Is the following statement true or false? Arm recoil is one measure of assessing a newborn's physical maturity. The answer is false. Immediate newborn period. Maintain airway patency. Ensure. So it's really important. Of course, we want our baby to be breathing, so airway. We have to establish effective ventilation. And so once we get the baby stabilized, then we're going to ensure proper identification. We have to maintain thermoregulation. And we have to give our vitamin K and eye prophylaxis. And recent studies, along with recommendations from leading maternal health experts, support using a towel to wipe secretions from the mouth and nose of newborns for stable newborns. So routine suctioning of the mouth and airway is not required. It's really important to always keep a bulb syringe near the newborn in case he or she develops sudden choking or blockage in the nose. And so we give vitamin K to prevent hemorrhaging. It can't be produced, bacteria can't produce vitamin K in the gut yet because it's sterile, so food has to be introduced. Eye prophylaxis is to prevent against gonorrheal eye infections. We give erythromycin. Newborn physical exam, we just go head to toe. We always listen to the heart rate, and we count the heart rate for a full minute. We count respiratory for a full minute. We listen to S1, S2, are there any murmurs? And we listen for adventitious breath sounds. And then we go head to toe after that. Once you get a baby crying, it's hard to count your heart rate or your respiratory rate where they are so fast. And we do all of our measurements, length, head to toe, head circumference, we over the occiput and over the brow, chest circumference, abdominal circumference, our vital signs. Then we look at the skin, and anything that we see, any variation, it's really important to document that very first time, because you don't want to not document and then something, mom sees something and says, oh, did you all hurt my baby? So, a Mongolian spot, the darker area, usually on the buttocks, that's really important. Your little nevus on your eyelids, the back of the neck. Head, size, anterior fontanelle, soft and flat, diamond shaped, closes between 12 and 18 months. Sutures, are they overriding or are they approximated? So a bulging fontanelle you might see with intracranial pressure. A sunken fontanelle you might see with a dehydrated child. And you want to make sure the outer canthus of the eyes meets the top of the ear, low set ears. You have to check those for some type of deformities. Okay, so face, eyes, symmetrical. Nares, we just occlude one after the other and make sure The baby can breathe through their nose because they're obligate nasal breathers. We put our fingers in, we check the hard palate to make sure it's intact. You can look for little Epstein pearls. Neck, we can move it from side to side to check for range of motion. Chest, we're going to check the nipples for breast tissue. That's part of your Ballard gestational assessment. Palpate the abdomen. You should hear breast sounds in all 4 quadrants. You should not be able to palpate any mass. Genitalia in the female, the labia, with the term baby, the labia majora should cover the labia minora. In your male, your testes should be down bilaterally, so you make it's really important to document that, and that the urethra is midline. We will palpate the back, make sure the back's intact. We look for little dimples above the anus, like a pilonidal cyst, tufts of hair, if anything draining out. Neurologic status, alertness, posture, muscle tone, and reflexes, and we'll talk about them in just a minute. Common skin variations. Vernix caseosa, thick white substance that protects the skin of the fetus. It's formed by secretions from the fetus oil glands and is found during the first or 2-3 days after birth in body creases and in the hair. It does not need to remove because it will be absorbed to the skin. But of course, when we don't give baths immediately, we wait to 12 to 24 hours. And then you've got your little stork bites, superficial vascular areas. Milia, or those little pearly white or pale yellow unopened sebaceous glands. You see them a lot on a newborn nose. Mongolian spots are benign blue or purple splotches that appear solitary on the lower back and buttocks of the newborns. And they can actually occur as multiple over the legs and shoulders. So it's just really important to document these. The spots are caused by concentration pigmented cells and usually disappear spontaneously within the first 4 years of life. They should not be confused with bruises caused by trauma. And then erythema toxicum, newborn rash. It's benign, idiopathic, generalized, transient rash that occurs in up to 70% of all newborns during the first week of life. So you've got these little papules, and it's got white stuff or yellow stuff, and there's really no pattern, and it's just caused by newborns' eosinophils reacting to the environment in the immature system. So there's at least a couple of those. Acrocyanosis is another one you need to know. That's just that persistent cyanosis of fingers, hands, toes, and feet that will go away. So you need to know some of those. I will ask some of those on your exam. The ones I discussed. Variations in head size and shape are on chapter 18, slide 18. So molding is the elongated shaping of the fetal head to accommodate passage through the birth canal. And you do need to know the difference. There will be a question on caput or cephalohematoma. So caput is localized edema on the scalp that occurs from the pressure of the birth process, commonly observed after prolonged labor, and it clinically appears as a poorly demarcated soft tissue swelling. It crosses suture lines, and the swelling will go down in about 3 days. Cephalohematoma is a localized subperiosteal collection of blood of the skull, which is always confined by one cranial bone. So the cephalohematoma does not cross the suture line. It's due to pressure on the head and disruption of the vessels during birth. And clinical features include it's well defined and does not cross suture lines. It's firmer to the touch. And sometimes it doesn't. It appears on the 2nd or 3rd day after birth, disappears within weeks or months. You can have increased bilirubin just because of the red blood cells, and sometimes there's even a fracture of the bone underneath these. Microcephaly, a head circumference more than 2 standard deviations below average or less than 10% of normal parameters for gestational age, caused by failure of brain development. And some of the kids, the Zika virus, fetal alcohol syndrome, are a couple of types of babies that you will see microcephaly with. And macrocephaly, that's a head circumference more than 90%. Typically, you see this with hydrocephalus. Okay, you're going to have some questions on these. So we all see our little Moro reflex when you kind of drop the head a little bit and the hands come up and it opens up and you got this, comes back, you got this little C that disappears in 3 to 6 months. And we want all of these because reflex, it means the CNS is good. The Babinski sign is another one that we do when we just like take our finger along the outside sole of the feet and the little toes just like spread open real quick. It's real cute. It goes away in about 12 months. So you need to know about those two reflexes, your Moro and your Babinski. And then talking about some conditions during newborn transition. It'll talk about this a little bit more in the next chapter, transit to captivity of the newborn. It's increased with C-sections when babies don't go down through the vagina and get that vaginal squeeze. So they got some retained amniotic fluid, and they've got areas of mixed match ventilation, perfusion, quotient ratios, and they actually have like intrapulmonary shunting. So they just have to breathe faster. So they just breathe faster, trying to keep their oxygen levels up. And it takes 2 or 3 days for them to reabsorb all that fluid, and then they will improve. So normally we just give them some oxygen. If they're breathing more than 60 breaths per minute, we normally will tube feed them. Physiologic jaundice, we'll talk about that more. Hypoglycemia, usually less than 40, and we can just initiate early feedings. We'll talk about that a little bit more. So with TTN, it's just talking about we're going to give our oxygen, we're going to keep them warm, we're going to monitor our vitals, and we're going to allow time for pulmonary, capillary, and the lymphatics to remove the remaining fluid because we can't suction that fluid out. Physiologic jaundice, that's the type of jaundice that starts usually the 2nd or 3rd day, just immaturity of the liver. Frequent breast or formula feeding, phototherapy. When they're under phototherapy, we have to be very careful to make sure we keep their eyes covered, and of course with the little black mask, and we keep the diaper on them, and we monitor their hydration status, stools, and skin color. So we have to, and you can do sometimes double phototherapy. You can do a blanket, you can do phototherapy over the head, and we can use our transcutaneous bilirubin. You just have to be sure you turn the light off when you do that, when that's non-invasive. And then we can also do a total and direct bilirubin with a heel stick. And you also make sure you turn the bilirubin light off when you do these. Nursing interventions for hypoglycemia. And each physician has different values that they will treat. And we've got some sweet toot. It's just I'm not sure what percentage dextrose it is that you can give orally or just early feedings. Monitor for symptoms. So if it's low, you're going to feed, and then you're going to have to recheck. And some babies, like severe IUGR or postmature, you may even have to go to IV fluids. PKU, it's really important. We do our metabolic screening. That's extremely important. I'm on slide 24. It's very important for us to do this screening because the reason it's so important, we can identify what's going on. And so PKU, phenylalanine, autosomal recessive inherited deficiency in one of the enzymes necessary for the metabolism of phenylalanine to tyrosine, which is an essential amino acid found in most foods. It's a lifetime diet of foods low in phenylalanine, low protein, monitoring of blood level, and you do have special newborn formulas available, Lofnalac and Phenex. So we just have to screen them because we want to prevent any mental retardation. So we screen them, we identify them, and then we get them all on these special types of formula. Hearing screening, we do that before discharge, and we're just screening for sensorineural hearing loss. And a lot of times, if there's a lot of vernix, they're going to fail in there. So we make an appointment and make sure it's at least over 2 weeks out, so that vernix can be reabsorbed. So we have to identify a hearing defect if there is one, because that affects vision development. So it's really important. So at 24 hours of age, we check our bilirubin, the transcutaneous bilirubin level, and we got a little nomogram. We just chart it to see if the baby needs to be checked more often. And if it's real high, we just go ahead and get a total and direct to see how high it is, because the baby may have to have phototherapy. And then we also do the O2 sats of the right wrist, which is preductal, and either foot, which is postductal. So we're just trying to rule out congenital heart defects at 24 hours of age. And then they all have to have an auditory brainstem evoked response. And that's your hearing screen before discharge. And then if they do fail, then you have to schedule a follow-up appointment. That's extremely important. And if there's any issues with family or whatever, you can always call social service. If it's a baby who has issues, maybe low APGAR scores, you're worried about their outcome, there is birth to 3. Just remember, as RNs, it's really important for you to know all resources that are available, because it's up to you to make sure these referrals are made. So now we're on slide number 25, nursing management, early newborn period, nursing interventions, general newborn care. And, I hand you the discharge sheet, that everything that we do. So cord care, soap and water, keep the cord dry. You don't cut the little fingernails for a couple of weeks, because the skin and fingernails are kind of grown together. And babies, if they have a CIRC, then if it's a Plastibell, they never pull the string. They just have to pour saline for diaper changes, and then you just do the teaching. If there's odor or discharge, they would notify the healthcare provider. And back to sleep is really important to decrease the incidence of SIDS. However, they do need tummy time, so you put them on their abdomen so that they can learn to lift that head and strengthen the shoulders, so that they can get ready for their 4-month or so roll. And then you feed them, you burp them, and then you lay them down in bed by themselves. It can be right beside you, back to sleep. So we're going to look at our diapers, their urination, and they're going to have 6 to 8 after a couple of days. Stool pattern, bathing, plain water on eyes, face and eyes, mild soap for the rest of the body. So we're not going to put soap. So we take a washcloth and we use 1/2 and go from inner to outer, and the other half, the opposite eye, inner to outer. And we just use soap and washcloth for the rest of the body. It's really important to try to keep them warm. Don't cold stress them during a bath. And as far as putting them in a tub of water, the cord needs to have fallen off. And Plastibell before you put them in water. Cord care, you've got teaching guidelines. Keep them dry, soap and water. Little boys fold the diaper down so that they don't urinate on the cord. If there's any drainage or odor, they'd need to notify their healthcare provider. CERT care, we go over that. Safety is really important. Car seats, they have to go home in a car. And we have hugs tag systems. Bracelets go on the babies and the parents. We identify the baby every single time we take it out, match the parent's bracelet. We teach them that the elevators and the doors, everything will close. If someone gets 6 feet away from an opening or the elevator. Hand hygiene is huge. Anyone sick needs to stay away. Sleep promotion, whatever sleep pattern they develop is what you will live with yourself. So it's up to you. Tummy time, play with them, feed them, burp them, put them down and let them go to sleep. Don't let people wake them up to play with them. And at night, they need the darkness with maybe a little night light, but no TVs. Don't get them used to all that stuff, because if you do, that's what you will live with. So it's just so important to tell them to develop good sleeping patterns from the beginning. Of course, bonding is very important. 27, we're talking about nutrition. Calories, about 110 kilocalories per day up to the first 6 months. And hopefully moms will breastfeed, but if they bottle feed, that's just as important. Breast milk can be room air for 8 hours, in refrigerator for 3 to 5 days, in a freezer for 3 months, in a deep freezer for 6 to 12 months. And you need to know that. You need to memorize that. And let's see where we're at. We're on slide 26. No, 28. Oh, as far as newborn safety, have emergency telephone numbers readily available. You should take CPR. We have an instructor that teaches CPR to all patients. Put safety plugs in wall sockets within a child's reach to prevent electrocution. Don't leave the infant in a room without a portable intercom on. Never leave a baby in a tub by itself. They can drown in 2 inches of water. Make sure your crib is sturdy, whatever it's approved. Smoke-free environment for all infants. Use sun shields on strollers and hats to avoid overexposing the baby to sun. And thoroughly investigate any healthcare facility before you use it. Okay. Breast milk and formulas contain about 20 calories per ounce. Most term infants need a basic formula if the mother chooses not to breastfeed. And these formulas are modified after breast milk, which contains 20 calories per ounce, and there's no recommendation to recommend one formula over the other. And we'll talk about composition of breast milk now on slide 28. Composition of breast milk changes over time from colostrum to transitional milk and finally to mature. Colostrum, I think there's a test question about this, is a thick yellowish substance secreted during the first few days after birth. It is high in protein, minerals, and fat-soluble vitamins. It is rich in immunoglobulin IgA, which helps protect the newborn's gastrointestinal tract against infections. It is a natural laxative that helps rid the intestinal tract of meconium quickly. So then between colostrum, after that we have transitional milk, then our mature milk. And our true or mature milk is around 10 days after birth. And it just says it can appear bluish. It's not as thick as colostrum. It provides about 20 calories per ounce. And of course it contains protein, fat, carbs, water, minerals, and vitamins and enzymes. Latch, so it's really important for the baby to take the nipple and about an inch around some of the areola. You bring the baby to the breast. You never stretch the breast. It should be tummy to tummy, baby's tummy to mom's tummy. Then the baby latches and it's sucking, and you don't pop off the baby, pop off the nipple. You take your finger, you put it in the side of the baby's mouth. This is really important, and break the vacuum so that the nipple comes off, the baby's mouth comes off of the nipple easily. You do not want no popping, because then you'll end up with cracks, and then you end up with mastitis. So the finger goes in the corner of the mouth, you break the vacuum, and then the baby's mouth will just open up and the nipple will come out. And, lactation consultants will tell you it's okay for babies to nurse every couple of hours. You'll set your own pattern. You have to be careful. Don't let them constantly suck, because they'll use you as a passy. And there is cream that you can put on the nipples, and there's little these little gel things, and there's different things that you can use if your nipples crack. And if the woman gets mastitis, it's just like a systemic infection, and you have to keep on breastfeeding. They have to go on antibiotics. So how many calories per kilo during the first 3 months? And I've already told you it's 110. And bottle feeding. So once we take them out, they feed with that bottle. They just need to throw it away and get a brand new bottle for the next time. And they normally just don't introduce food, baby food, until around 5 to 6 months, when that protrusion reflex is not so dominant, because it will just kind of, like, it's hard to get the spoon and the cereal in. And you start with your cereal, iron fortified, and then you go, I just say vegetables, and then fruits, and you introduce stuff about every 5 days or so to make sure there's no allergies. And discharge. Cultural variations are extremely important. Always a return visit. And it's a baby that's jaundiced, they may go home and have a lab slip to repeat a bilirubin the next day, to make sure that the bilirubin is still staying down. If mom was group B strep, there's a handout saying for signs and symptoms that they should look for. Immunization information. They get their first Hep B. We use a 25 gauge, I think it's 5/8 needle, inch needle, for IM injections with babies, and not more than 0.5 mil IM. Okay, let me see if there's anything else. Okay, this says breast milk use. Sealed and chilled milk within 24 hours. Well, this says discarding milk that has been refrigerated more than 24 hours. And my other slide said 3 to 5 days in the refrigerator. Use frozen express milk within 3 months. So regular freezer is 3 months. Deep freezer is 6 to 12 months. Do not use microwave ovens to warm chilled milk. You just put them in a cup of hot water. And you never refreeze your milk. Store milk in quantities to be used for in each feeding, so that you put them in those little containers, 2 to 4 ounces. Thaw milk in warm water before using. Okay, let's see. Bottle feeding. Introduction to solid foods. Let's see this. It says when infant doubles their birth weight and weighs at least 13 pounds, it's time to consider introducing solid foods. Readiness cues include consumption of 32 ounces of formula or breastfed milk daily, ability to sit up with minimal support and turn head away to indicate fullness, reduction of protrusion reflex so cereal can be propelled to the back of the throat, demonstration of interest in foods other around them are consuming, ability to open mouth automatically when food approaches it. New food should be introduced one at a time, a week apart, so that if a problem develops, the responsible item can be identified. Infants should be allowed to set the pace regarding how much they wish to eat. Infants should never be force-fed. All right, let's go see if we can get another chapter up. Okay, so nursing care of the newborns with special needs. This is chapter 23. Factors affecting fetal growth. So most newborns are born between 38 and 42 weeks of gestation, weigh 6 to 8 pounds. However, variations in birth weight or the gestational age can occur, and newborns with these variations have special needs. Risk factors associated with gestational age and birth weight variations include maternal nutrition, genetics, placental function, environmental factors. Birth weight variations appropriate for gestational age. Approximately 80% of most newborns, normal height, weight, head circumference, and body mass index, and we just take all of these measurements and just chart them on the growth chart. Small for gestational age, SGA, weigh less than 2,500 grams at term or below the 10th percentile. And large for gestational age, weights above the 90th percentile on a growth chart, weight is greater than 4,000 grams or 8 pounds, 13 ounces at term. So these large for gestational ages, some of the things we worry about is birth trauma, fractured clavicles, and a fractured clavicle is the most common fracture that happens to infants, increased with shoulder dystocias. Also, like if it's an infant of a diabetic mother that's really large, those infants may have hypoglycemia. So variations: low birth weight, infant weighing less than 2,500 grams or 5.5 pounds. Very low birth weight, infant weighing less than 1,500 grams or 3 pounds 5 ounces. Extremely low birth weight, infant weighing less than 1,000 grams or 2 pounds 3 ounces. Small for gestational age. Conditions affecting fetal growth under 28 weeks, leading to overall growth restrictions. They never catch up in size. Greater than 28 weeks, intrauterine malnutrition, normal potential. So they're just talking about asymmetric versus symmetric IUGR. I'm not asking about any questions about that. Your asymmetric, the ones with the brain sparing, have a much better prognosis than the one that has had the insult during the entire pregnancy. And the head, the length, everything is smaller. Fetal growth restriction is the pathological counterpart of small for gestational age. So symmetric fetal growth restriction refers to fetuses with especially poor growth rates of the brain, the abdomen, and the long bones, and is thought to result from an early global insult. All parameters are affected. Asymmetric, the brain is spared, and they have a much better prognosis. This is just showing some small for gestational age newborns. So small for gestational age, this is showing just the head is large compared to the rest of the body. Wasted appearance of extremities, loose dry skin, reduced sub-Q fat stores, decreased amount of breast tissue, scaphoid abdomen, which is sunken in, wide skull sutures and poor muscle tone, thin umbilical cord. So we're going to monitor these babies for temp instability, for low blood sugar. So these babies are more prone to like birth depression, have a harder time, see where they've got decreased sub-Q fat, so therefore they have a harder time managing their temperature, so difficulty with thermoregulation. And then they also have low blood sugars, polycythemia, just from constant stress, so therefore they produced more red blood cells, and polycythemia, like a venous hematocrit, I think that less than above 65, And we just have to worry about that because when it gets really thicker, it can increase incidence of stroke. Meconium aspiration. Meconium normally you see with your more post-term babies. Issues with bilirubin and birth trauma. So we're going to monitor the glucose, vital signs, early and frequent oral feedings. We may have to go ahead and use some D10. Always monitor for signs and symptoms of polycythemia because they're more prone to hyperbilirubinemia and phototherapy. The majority of small for gestational age newborns experience IUGR. That is false. Some do and some do not. Risk factors for large, and we always worry about these large for gestational age infants. Large body. Went too far. We're on slide number 12. So maternal diabetes is where the glucose crosses the placenta and the baby has to increase the production of insulin. Insulin acts like a growth hormone. So then once the baby's born and they're no longer receiving all that glucose from mom, they still have all that insulin on board. So those babies can end up with hypoglycemia. So it's really important to monitor IDM, infant of a diabetic mother. And the more babies you have, each one usually is larger than the one preceding. And then if you got a prior history of a macrosomic infant, post-dated gestation, maternal obesity, males are bigger, and then genetics. So common characteristics: large body, plump, full-faced, proportional increase in body size, and then there's poor motor skills, difficulty regulating behavioral states. A newborn will have a wasted appearance. That's false. Large body, plump, and full-faced. Common problems: birth trauma. May be more difficult to go through the birth canal. They have increased risk for shoulder dystocia. Shoulder dystocia is a complication that occurs during delivery when an infant's shoulders become lodged in the mother's pelvic, often because the baby's proportionally too big for the birth canal. Cephalopelvic disorder known as CPD. And with a shoulder dystocia, the nurses may do McRoberts maneuver procedure to flex hips up and out. Suprapubic pressure, lock elbow and push down behind suprapubic bone. Press on the shoulder. Do not do fundal pressure, dangerous and can rupture the uterus. Hypoglycemia. Fetal macrosomia is more likely to be born with a blood sugar level that's lower than normal. Research suggests that the risk of childhood obesity increases as birth weight increases. And then your polycythemia, defined as a venous hematocrit above 65 and hemoglobin more than 20 grams. So, of course, we're going to monitor our vital signs, our glucose, early feedings, and we're going to watch the H&H, blood sugar, make sure they're hydrating well, and phototherapy if needed. Our gestational age variations term is from the first day of the 38th week through 37 weeks. Premature is born before completion of 37 weeks. So you can have like 37, 1/7, 2/7. That's the way they chart it. A late preterm term is born between 34 and 36 and 6/7 weeks. Post-term is born beyond 42 weeks. Let's see if there's anything else. Okay, a post-term newborn may be born at 43 weeks. You think it could be LGA. However, it may also be SGA or dysmature. just because remember the placenta typically starts aging on its own after 40 weeks. Post-term newborn, inability of placenta to provide adequate oxygen and nutrients to fetus after 42 weeks. So typical characteristics of your post-term newborn: dry, cracked, wrinkled skin, possibly meconium stained, long, thin extremities, long nails, creases cover entire soles of feet, wide-eyed, alert expression, abundant hair on scalp, thin umbilical cord, limited vernix and lanugo. They look like a little old man or woman. In the post-term newborn, one issue is that there is an inability of the placenta to provide adequate oxygen and nutrients to the fetus after 42 weeks. Abundant hair on scalp, thin umbilical cord, limited vernix and lanugo. And one thing we worry about with them is meconium aspiration and persistent pulmonary hypertension of the newborn. And we'll talk about that a little bit in chapter 24. Resuscitation. We lay the baby down. We dry our baby. We position it. We suction the mouth and the nose. We stimulate it. So we resuscitate as needed. And then afterwards, we'll check our glucose and give feedings if needed. We're going to prevent heat loss, having everything warm before the baby's born. And then, of course, we're just going to do some labs, check for polycythemia, check for glucose. Preterm births. Infections, inflammation, maternal or fetal distress, bleeding, stretching. Factors that stretch the uterus can cause contractions, which in turn can trigger early labor. Factors include having multiple babies, excessive amniotic fluid, fibroids in the uterine wall, and having a large baby. Preterm newborns face a lot of issues. Their survival rates are increasing. However, they are at high risk for neurodevelopment disorders such as cerebral palsy. So we've got immaturity, which affects transition to extrauterine life. So we've got increased risk for complications with their respiratory system, respiratory distress syndrome, cardiovascular, GI, renal, immune, and central. Characteristics: usually under 5.5 pounds, scrawny with poor muscle tone, minimal sub-Q, testes aren't descended, lots of lanugo, fused eyelids. We're talking really premature, like 26 weeks. And their little ears, if you bring them forward, they just stick like a real preemie. Absent a few creases in soles and palms, and that has to do with your gestational age assessment. Prominent labia and clitoris, thin transparent skin. So we have our characteristics of our preemies. So the answer is you're going to have few palmar creases. Preterm newborn characteristically has few or no creases on the soles of the feet and palms. Common problems: they have issues keeping their temperature up, keeping sugar up, hyperbilirubinemia, and there's no set level as to what hyperbilirubinemia is in the smaller infants, because if they're sick, it's even lower. So you just have to monitor them. And oxygen, we use nasal cannulas a lot. And we can put them in an isolette or under a radiant warmer, infant servo control, We can NG feed them. We can give them IV fluids, TPN, and lipids. Infection prevention. If they're real preemie, we try to cluster activities and not overstimulate them. Pain management. There are pain scales. Parental support. It's really important. You know, at preemie's firstborn, you may have to kind of lead the parents up because they're kind of sometimes really afraid of the little ones, afraid that they'll hurt them. And our late preterm versus preemies, you just need to look at all of those categories. Discharge is really important. Parental education. Are they going to have follow-up? And we'll talk about if they were in oxygen, they have to be examined by an ophthalmologist for retinopathy of prematurity. They may have to be followed by birth to 3. They may need CPR. Some of them occasionally on oxygen may go home on oxygen and or monitors, so they'll need home health. Dealing with perinatal loss. So if a baby's born with a congenital defect that the parents weren't aware of, you need to show it to them as soon as possible and just explain, give them time to absorb it. If a baby dies, you need to let them hold the baby. It's really important if they give the baby a name. You can take photographs. They may not want them. They may come back in a year or 2 and want the photographs. If they initially didn't want the baby and then 3 or 4 hours later they want the baby, you get that baby, put it back under a radiant warmer and warm it up, then wrap it up, put a little outfit on it, and then let the parents have it. So it's just so important if they will hold that baby, name that baby. The loss of a baby it's horrible. Okay, so we'll go on. Let's see if there's anything else. Okay, so we're going to go on to chapter 24. So we have our acquired disorders typically occur at or soon after birth. Problems or conditions experienced by the woman during her pregnancy or at birth, and there may be no identifiable cause for the disorder. Congenital disorders are present at birth, usually due to some type of malformation occurring during the antepartum period, typically some problem with inheritance. So your acquired disorders: diabetes, maternal infection, substance abuse, conditions associated with labor and birth, such as prolonged rupture of membranes or fetal distress. Congenital disorders: the most common serious defects are congenital heart defects, neural tube defects, and Down syndrome. Congenital disorders, which often involve a problem with inheritance, include structural anomalies, commonly referred to as birth defects, chromosomal disorders, and inborn errors of metabolism. Most congenital disorders have a complex etiology. And this just goes through a whole list, and we'll just look at some of them. Hypoxic ischemic encephalopathy. This is our birth depression. Occurs, and we don't really use this word asphyxia. We like to use birth depression. Occurs when adequate breathing is not established after birth, insufficient oxygen delivery to meet metabolic demands. Asphyxia is the old name. The new name is hypoxic ischemic encephalopathy, and it's the most common clinical insult in the perinatal period. Results in brain injury, may lead to mental retardation, cerebral palsy, or seizures. Failure to establish adequate sustained respirations after birth. Pathophysiology: insufficient oxygen delivery to meet metabolic demands. Nursing assessment: risk factors, newborn color, work of breathing, heart rate, temperature, APGAR scores, and nursing management: immediate resuscitation, continued observation, provide neutral thermal environment, monitor and maintain blood glucose levels. And actually for this HIE, you can use that protective hypothermia, and you have to do that at tertiary centers that have the protocols for hypothermia. And then according to the American Heart Association and American Academy of Pediatrics, your book says that resuscitation can stop after 10 minutes. That's not true. The 8th edition of NRP, as of June the 1st, now says that after you've intubated, you've established central lines, and you've given your meds, you give your meds, after 20 minutes of no heart rate, then you can stop. Now that's a long time. Transit tachypnea of the newborn increased with C-sections who didn't get vaginal squeeze. They have retained amniotic fluid, mild respiratory distress, pulmonary liquid removed slowly or incompletely, and the lymphatics and capillaries usually reabsorb all of it, take care of it by about 72 hours of age. So maternal sedation or birth by C-section are risk factors. So we have tachypnea, that's respiration greater than 60, expiratory grunting, exhaling against a partially closed glottis, retractions, labored breathing, nasal flaring to decrease airway resistance, mild cyanosis, respiratory rates, they can be really high, 100 to 140, barrel-shaped chest, slightly decreased breath sounds, and your chest x-ray for transient tachypnea of the newborn will show mild symmetric lung hyperaeration with prominent perihilar interstitial marks and streaks. So we're going to provide oxygenation, supportive care, IV fluids or gavage, whatever they need, supplemental oxygen, neutral thermal environment. So that is slide number 6. And we'll provide ongoing assessment of the newborn's respiratory status. As transient tachypnea of the newborn resolves, the newborn's respiratory rate declines to 60 breaths per minute or less. Oxygen requirement decreases. Chest x-ray shows resolution with the perihilar streaking. Provide reassurance and progress reports to the parents to help them cope with this crisis. Anytime a baby ends up, in the nursery having to stay in, it's a crisis because the parents didn't get what they expected. Neonatal asphyxia commonly resolves within 72 hours after birth. That's false. We're talking about transient tachypnea. Respiratory distress syndrome. I know there's a question about this. Lung immaturity, lack of alveolar surfactant, which is a phospholipid that decreases surface tension so the alveolus do not collapse at the end of expiration. So signs and symptoms of RDS: expiratory grunting, nasal flaring, chest wall retraction, seesaw respirations, generalized cyanosis, heart rates 150 to 180. They've got the fine inspiratory crackles, respiratory rate, tachypnea above 60. And there's a Silverman-Anderson index score that you can use in your book. Chest x-ray, you need to know this, the ground glass pattern that you see just where the alveolus are just partially filled with air. So RGS, lack of alveolar surfactant. Chest x-ray will show ground glass pattern, and you can give them surfactant to decrease that surface tension, keep the alveola open. This is your Silverman-Anderson score. As far as our nursing management, we're going to give them the surfactant, which forms a coating over the inner surface of the alveola, reducing the surface tension, preventing alveolar collapse at the end of expiration. So whatever type of oxygen support they need, we use our nasal cannulas. We can use CPAP with the little nasal prongs. If they have a sepsis, positive blood culture, you can put them on antibiotics. Of course, you're going to give them their fluids. We usually start about 80 ml per kilo per day, divided in 24 hours. D10. If the baby weighs less than a kilo, we start with D5. If they're really tachypnic and breathing fast, you're going to give Gavage feedings. We're going to monitor the glucose. We're going to cluster our care, put them on prone or sideline, and then parent education is extremely important. And you can have a lot of complications from respiratory distress syndrome, but we don't see the bronchopulmonary dysplasia that we used to see ever since 1986, when the first surfactant clinical trials were done at 4 hospitals throughout the United States, and West Virginia University was one of the 4 in the EXO-SURF clinical trials, and I actually was a part of that research study because that was the very first year of the neonatal nurse practitioner program. Complications of respiratory distress syndrome. So air leak, you can have your pneumos, bronchopulmonary dysplasia, chronic lung disease. Ductus can stay open. It may have to be tried to close it with indomethacin or surgery. Intraventricular hemorrhages, you always have to worry about, periventricular hemorrhage and intraventricular hemorrhage, because they may end up with some disabilities, learning disabilities. Retinopathy of prematurity, that's the reason they have to have any baby that's on oxygen any length of time has to be examined by an ophthalmologist. Necrotizing enterocolitis, we'll talk about that in a minute. And then, of course, all of your catheters, you can always have clots where you use your UACs and UVCs. And then you can always have developmental delay or disabilities. Meconium aspiration syndrome, probably will be a question about that. Meconium aspiration syndrome, staining of amniotic fluid, barrel-shaped chest, prolonged tachypnea, retractions, grunting, cyanosis. Your chest x-ray with meconium aspiration, you need to know this. Puffy, patchy, fluffy, infiltrates, kind of looks like cotton candy. Of course, you're going to have your metabolic acidosis and respiratory acidosis. And these babies may have to be on a ventilator. They may have to go for oscillation or even ECMO if they also have persistent pulmonary hypertension of the newborn. Bronchopulmonary dysplasia, chronic lung disease. This is continued need for oxygen after 28 days of life. You really see it with your preemies more often. And then you just have to try to use steroids in the moms to prevent this. Then you're going to give surfactant trying to prevent it. Close a PDA early. Monitor O2 sats, keep as low as possible. So you're going to do everything you can to get them off of the ventilator and prevent this. Retinopathy of prematurity, developmental abnormality affecting immature blood vessels. So when they're exposed to high oxygen, you've got severe retinal vasoconstriction with endothelial damage and vessel obliteration. So then abnormal blood vessels develop in an attempt to nourish the retina. And these vessels, which peripherate into the retina, are very fragile. They bleed easily. They form scar tissue, and they can enlarge and twist, pulling the retina away from the wall of the eye, resulting in retinal detachment. And so that's the reason they have to have laser or cryo surgery. And these ophthalmologists can look at them and see which ones need this surgery and which they think will be all right. So always give your oxygen at the lowest possible concentration and the shortest duration. Meconium aspiration syndrome. Hopefully, it doesn't happen, but if it does, you just have to assess your baby at birth. Persistent pulmonary hypertension of the newborn, that has to be diagnosed with an echocardiogram, and that's when a newborn with persistent pulmonary hypertension demonstrates Tachypnea within 12 hours after birth. They have marked cyanosis, grunting, respiratory distress with tachypnea and retractions, hypotension relating from both heart failure and persistent hypoxemia. Prepare the newborn for an echocardiogram, which will reveal right to left shunting of blood that confirms the diagnosis. And you just have to give early effective resuscitation. You have to give oxygen therapy. You're trying to prevent this persistent pulmonary hypertension. And, I've told you blood follows the path of least resistance. So those pulmonary arteries stay, if they're constricted and they're thick and you can't get the blood to the lungs, then you can't oxygenate the blood. So that's the issue, is the blood pressure in the lungs is higher than the systemic blood pressure, so you can't get your blood to the lungs to be oxygenated. And this is just talking about all the things that you have to do. And sometimes these babies will end up on ECMO, blood being oxygenated outside of the body, and just very minimal support to the lungs so that the lungs, the vessels can relax and the blood pressure can go, the pulmonary pressure can go down. And then they'll slowly wean them off of that and wean them off of the ECMO. And it's very complicated management to deal with persistent pulmonary hypertension of the newborn. I had to take a baby to DC for ECMO and then go back and get it. So, problem with meconium aspiration syndrome in utero involves hypoxic stress, and that is true because the baby gets stressed with hypoxia, and then they're going to pass meconium. Periventricular and ventricular hemorrhage, there is going to be a test question on that. And bleeding in the brain due to fragility of cerebral vessels, those little tiny preemies cannot auto-regulate their cerebral blood flow. So that's the reason they do C-sections instead of letting the cervix clamp down on their little heads. And then if you have to resuscitate them, you have to give the fluids very slow. If you slam a bolus in, those little vessels in the head can pop open. So we just have to monitor them, do an ultrasound of the head to see if they have a bleed. Unexplained drop in hematocrit, pallor, poor perfusion, seizures, lethargy, weak suck, high-pitched cry, and hypotonia. So we just have to, look at this, and if it's severe enough, they may end up with some hydrocephalus, and they may even have to have shunts. So hopefully we can prevent this, correct anemia, acidosis, and hypotension. And flex contained positioning, daily head circumference, cluster or care, limits stimulation. Complications resulting from intraventricular hemorrhage include hydrocephalus, seizure disorders, periventricular leukomalacia, which is an ischemic injury resulting from inadequate perfusion of the white matter adjacent to the ventricles, cerebral palsy, learning disabilities, vision or hearing deficits, and cognitive impairment. So blood vessels of the germinal matrix are weak-walled and predisposed to hemorrhage. A significant stress experienced by a premature infant after birth may cause these vessels to rupture. When the bleeding occurs, it may be in the periventricular area, causing a periventricular hemorrhage. If the bleeding persists, the expanding volume of blood dissects into the adjacent lateral ventricles, leading to an intraventricular hemorrhage, or IVH. And most of these hemorrhages are going to occur within the first 72 hours of birth. Necrotizing enterocolitis. There's going to be a question on this. 3 pathological mechanisms. You've got bowel ischemia, bacterial flora, and effective feeding. And usually you sit with your preemies, they don't tolerate their feeding. You do abdominal circumferences, so abdominal distension, your abdominal circumference increases, they're tender. They have bloody stools. Now, they can also have like a bright green or yellow, vomitus, feeding intolerance with this bilious vomiting, septic, lethargic, apnea, shock. You get a KUB, kidney ureters, bladder, air and bowel wall. That's called pneumatosis. And the air can go all over the place. So with Nick, you have to make them NPO. You got to put them on IV antibiotics. You got to watch because sometimes you have bowel necrosis, and actually they'll have to be transferred out, and they may have to have surgery and lose some of their bowel. So hopefully we can prevent it. Now there's bigger babies like congenital heart defects with low APGARs that also are at risk for developing necrotizing enterocolitis. So it's not only your preemies. So you need to know your signs and symptoms: abdominal distension, bloody stools, feeding intolerance, sepsis, lethargy, maintenance of fluid and nutritional therapy, bowel rest, antibiotic therapy, IV fluids, and they may have to have surgery. Which of the following would the nurse expect to assess in a newborn with necrotizing enterocolitis? Abdominal stension. So NEC is an inflammatory disease of the bowel which can cause ischemic and necrotic injury in the gastrointestinal tract. It is the most common and most serious acquired gastrointestinal disorder among hospitalized preterm neonates and is associated with significant acute and chronic morbidity and mortality. Infants of diabetic mothers. Slide 29, chapter 24. Or slide, yeah, that says 20. Okay. High levels of maternal glucose crosses the placenta, which stimulates increased fetal insulin production, and that increased insulin acts like a growth hormone and leads to somatic fetal growth. So mom has diabetes, the baby will be full, rosy cheeks, ruddy skin color, short neck, buffalo hump, massive shoulders, distended upper abdomen, excessive subacute fat, hypoglycemic, and they're prone to birth injury. They can also have hypocalcemia, hypomagnemia, hyperbilirubinemia. Hey, I'm lecturing. Okay, thanks. So hypocalcemia, hypomagnesia, polycythemia, and hyperbilirubinemia. Infants of diabetic mothers, nursing management. So if you can just get their glucose under control, that's extremely important with diet, with medications, so that the babies, don't receive all this extra glucose and produce extra insulin and end up with all of this growth. So prevention of hypoglycemia, and you do know they're prone to it, so you're going to do oral feedings, neutral thermal environment, rest periods, maintenance of fluid and electrolyte balance, parental support. And then the next thing we're going to talk about newborns of substance abusing mothers. Talk about neonatal abstinence syndrome. And, we see a lot of opioids. However, the most common substance really is alcohol. So fetal alcohol syndrome, they have those physical and mental disorders that appear at birth, remain problematic through the child's life. And they have thin lips, eyes that are close together, microcephaly, learning disabilities, And they call it now fetal alcohol syndrome spectrum disorders. And as far as our drugs, neonatal abstinence syndrome, drug dependency acquired in utero, manifested by neurologic and physical behaviors. And the fetal alcohol syndrome is a done deed. Birth to 3, whatever. NAS, some babies can be weaned off, and their outcomes is truly unknown. You just have to watch them as they, their developmental milestones. Do they meet them? And like fetal alcohol syndrome, there's like some may be barely affected. You may not even know it and not see it until later on when they're in school. But just the fetal alcohol syndrome, you just need to know the craniofacial facies and the microcephaly. And maternal history, risk behaviors, and then we just check, we send the records out for toxicology, and then we have our scales that we do, withdrawal assessment, and then we use our medications, morphine, methadone, and then just try to wean the babies off. And this is just talking about fetal alcohol spectrum disorders. So they're small for gestational age, small eyes, thin upper lip, microcephaly. Alcohol now is recognized as the leading preventable cause of birth defects and developmental disorders in the United States. So birth traumas, injuries due to forces of labor and birth. And I said clavicle fracture is your most common fracture. You can have your brachial plexus injuries, cranial nerve trauma, head trauma, cephalohematoma. And you just have to observe the babies and identify whatever the issue is. Hyperbilirubinemia, physiologic jaundice, 3rd to 4th day of life. Pathologic jaundice usually occurs within the first 24 hours, and it is most commonly the result of hemolytic diseases of the newborn, your Rh isoimmunization or your ABO incompatibility. So if you've got significant jaundice in the newborn less than 24 hours of age, should be immediately reported to the physician, as it may indicate a pathologic process. Because when bilirubin gets a certain level in the blood, it'll cross the blood-brain barrier and layer into your basal ganglia. And once connectors occurs, it's irreversible. You've got irreversible brain damage. So we really shouldn't be seeing this at this point in time, because we're going to do the transcutaneous bilirubin at 24 hours. We're going to monitor these babies, observe these babies. We're going to teach the parents of, the baby's yellow, lethargic, not voiding or eating, to contact the healthcare provider. So all of this health promotion and prevention is the key to all of this. If they do have hyperbilirubinemia, we got to reduce those bilirubin levels, early feeding, phototherapy. We have to cover the closed eyes with the little black protective eye covers. If it's high enough, we may have to exchange transfusions. You may do a partial, where you just put normal saline in, take blood out. Or if it's severe, you may have to do a complete exchange transfusion. Home phototherapy, you can use that. Bilirubin has 2 forms, unconjugated or indirect, which is fat-soluble and toxic to body tissues, and conjugated or direct, which is water-soluble and non-toxic. Elevated serum bilirubin levels were manifested as jaundice in the newborn. So jaundice is yellow discoloration of the skin and sclera of the eyes, caused by increased levels of bilirubin in the newborn circulation. Physiologic jaundice is an unconjugated hyperbilirubinemia, common, normal newborn phenomenon that appears during the 2nd or 3rd day of life, then declines over the first week. Physiologic jaundice, difference between breastfed and bottle-fed newborns in relation to the onset of symptoms. And as far as phototherapy, keep the lights about 12 to 30 inches or above your newborn. Protect the eyes with patches. Keep the newborn undressed except for the diaper area. Turn your newborn every 2 hours so that all areas of the body are exposed. Stools, bilirubin stools, will be loose and green as the bilirubin is broken down. Keep the skin clean and dry to prevent irritation. And then, of course, you've got to feed your baby. Rh incompatibility most commonly arises with exposure of an Rh negative mother to an Rh positive fetal blood during pregnancy or birth, during which time erythrocytes from the fetal circulation leak into the maternal circulation. Isoimmunization can also occur during an amniocentesis, ectopic pregnancy, placenta previa, placenta abruption, in utero fetal death, spontaneous abortion, or abdominal pelvic trauma. After a significant exposure, alloimmunization or sensitization occurs. As a result, maternal antibodies are produced against the foreign Rh antigen. Once sensitized, it takes about a month for Rh antibodies in the maternal circulation to cross over into the fetal circulation. In 90% of cases, sensitization occurs during delivery. So that's the reason we give that RhoGAM. Standard dose is 300 mics, which is effective for 15 milliliters of fetal blood cells. Rh immunoglobulin helps to destroy any fetal cells in the maternal circulation before sensitization can occur, thus inhibiting maternal antibody production. This provides temporary passive immunity, therefore, for preventing maternal sensitization. And your ABO is limited to O moms with babies that are A or B, and this can actually happen with a first-time mother. It's much less common than your RH. Neonatal infections, sepsis, can be bacterial, fungal, or viral. Microorganisms or their toxins in blood or other tissues. You can have congenital intrauterine, early onset or late onset. Signs and symptoms, temp instability, pallor, hypotonia, cyanosis, jaundice, nasal flaring. They're lethargic, poor feeding, abdominal distension. Of course, you're going to do your septic workup, your C-reactive protein, which just enzyme system in the liver, which elevates in the presence of inflammation, your blood cultures, positive if they grow something. So antibiotic therapies, we just normally use ampicillin to cover gram-positive and gentamicin and aminoglycoside to cover gram-negative, and then the ampicillin also covers listeria. Circulatory, respiratory, nutritional, developmental support, and hopefully we can prevent this. Congenital conditions, neural tube defects. And we'll look at, see, okay, esophageal atresia and tracheoesophageal fistula. So with the esophageal atresia, congenitally interrupted esophagus, tracheoesophageal fistula, that's just an abnormal communication between your trachea and your esophagus, and they will just have all kinds of excessive saliva, just copious frothy bubbles. If you try to feed them, you're going to end up with those 3 C's: coughing, choking, and cyanosis. You always, a risk factor is polyhydramnios. Nursing management, NPO, elevate the head of bed. You've got intermittent suction. So they just have to have, you need to just identify this, and then there is a repair. And Omphalocele, there's a photograph in the book, just shows a umbilical ring defect with evisceration of abdominal contents. Gastroschisis, there is no sac, so you've just got your abdomen, your intestines on the outside of the abdomen. So, you've got to hopefully identify this before, have them in a tertiary center, pre-op care preventing hypothermia, and you just put the contents into a plastic bag, maintaining perfusion to abdominal contents, protecting exposed contents from trauma and infection. I'm not asking any questions about these. They're really complicated, and you just have various outcomes. The best outcome is going to be in a tertiary center with a surgeon who's experienced with these, and NICU people. Imperforate anus, rectum just ends in a blind pouch, and they have to have surgery also. I'm not asking anything about that. Bladder outside of the body, and I'm not asking anything about that. So I will try to get your test done and get you a study guide up sometime tomorrow. Hopefully you were able to see the slides, and you will be able, if you were on, you would have been able to hear me. I'm still live in Collaborate, so I am going to stop recording, and I will get you the test finished and get you I'll stop sharing.